going to talk about radiation monitoring. We wear our dosimetry badges when we're in the hospital, and we should especially be wearing them when we're inside the radiology room. Inside this plastic is a small piece of film that is sensitive to certain types of radiation. We send them off to a company quarterly, and they measure the amount of radiation that we're exposed to. When they're done measuring that radiation, we receive a report. This is a report for myself, and it is up through the year to date in this column. And I have received 3 REMs year to date, and our maximum permissible dose is 5 REMs per year. If someone does go over, we have to restrict their access to radiology so that they are not receiving too much radiation. Okay, we're going to talk about PPE, or personal protective equipment. I have my apron here, and you can see there's no major creases or folds or tears. We've recently x-rayed them for inspection to make sure that they are safe to use. We also have our thyroid shield, also no creases, tears, or cuts visible, and our gloves. We also can use protective goggles. We don't have those in our hospital. The next thing we'll do is we will put on all of our protective equipment so we can start shooting video, including our dosimetry badge. And our badge should be worn at thyroid level. We'll be discussing radiation safety now. We can use 3 methods of restraint for radiology. We can use manual restraint while wearing our PPE, chemical restraint such as sedation or anesthesia. We can also use positioning aids such as rolled gauze, tape, and our foam troughs, which kind of help position our patient, keep them from rolling from side to side. We can use the gauze and tape to help position their limbs and keep them from moving around. It also gives us more distance from the primary beam. We want to use distance and effective techniques to minimize our exposure to the primary beam and the scattered radiation. No part of a person should ever be in the primary beam because the ionizing radiation can cause permanent or temporary cell damage. Non-essential personnel should always be outside of the radiology room to help minimize exposure. Diagnostic images, we always try to get on the first try. That does limit the time we are inside the radiology suite and being exposed. Pregnant women should not be in the radiology suite because of the ionizing radiation that can affect the fetus and lead to complications further down the road, such as radiodermatitis or leukemia. Persons under 18 should not have exposure. They are more sensitive to radiation, and they have a higher risk of developing cancer later in life. So it's important that we always wear our PPE, including our thyroid guards, aprons, gloves, and our dosimetry badge so we can measure how much radiation we're receiving. Go. We'll be adding a patient to our digital x-ray. So we have our first line here, and we have patient first name, patient last name, and okay, we'll go back to that name in just a minute. I'm not sure where our keyboard is disappearing, so... Okay, we'll move it over here. Okay, so we have our patient first name, patient ID, weight, owner last name, and species. We'll move on to the next one, and we will be able to select our views that we're doing here. I'm going to start with a craniocaudal radius ulna. So we will go with, we'll do a right forelimb and radius, and we have our craniocaudal here. So we can begin. Doing our cranial caudal radius ulna. I have our dog in central recumbency right now. So we are going to collimate. We have our light coming on and we need to position him where we have mid-shaft is going to be where we're centered on. And we can collimate just a little bit to make this smaller. Okay, and to help us keep his foot still, we will be using a piece of tape so we can also be a little bit further away from the primary beam. Okay, we have him positioned. We'll just need to move his head, and we also need to adjust our settings. That will be more appropriate. We have our chart on the wall here, and our extremity, we want to be at 3.5 MAS and 80 kVp for his size. So we can see down here we are already at the proper settings. So we'll get him back into position, move his head out of the way, and take our radiograph.
How many Oreos before that happened? Huh? You tried it?
Judy.
I've had my own.
We have our film here, and we'll be able to add our marker. And we have our marker on, and we're finished with that view. We're going to be doing a ventrodorsal view of the thorax. We have a patient here, and our computer system automatically requests our x-rays, but if we were to manually add a patient, we would push our plus button, enter in patient name, first name, last name, patient ID, the weight, date of birth, species, and owner information, and then we would hit the next arrow to select our study. Since the computer automatically requests the study for us, we can see this is our patient Zoe that needs her x-rays done, and we can click on the play button, and it's set up for a 3-view thoracic film. So we'll start off selecting our VD, and since we know her weight already, we can use our technique chart. She's between 46 and 80 pounds, so for thoracic we need 80 kVp and 5 MAS. And on our knobs here, we are already at 80 kVp, but we need to increase our MAS. So we're at 5. Once we have her in the trough, we will collimate from the thoracic inlet to the first lumbar vertebrae, and we want to include the edges of the body wall for our lateral collimation. We'll center along the midline, and we'll get started. We have our patient here in the trough, so we're going to start by collimating. We want to include her thoracic inlet. Our cardiologist likes to have the last rib included. She's likely going to be a 2-view for each side that we're doing, so we won't be able to fit the entire chest cavity in one film. Have her collimated to her body walls. We need to get her midline centered. Trough will help us keep the sternum superimposed over the spine. And we'll add our right-sided marker to her right axillary area. Finish getting my PPE on before we shoot this film here. We're going to try to time our film for an inspiratory view because she is a cardiac patient and she's having a little respiratory distress, we may not be able to do that. Shooting. Here's our first view. For our second, we would move down further caudally to get the second field, but that is basically how you do a VD thoracic film. We'll be doing a VD view of the pelvis on a dog. The dog's currently under anesthesia, so we're going to go ahead and get set up in here first. Before we get set up, we'll kind of talk about positioning. We want to collimate at the level of the wing of the ilium, and distally we want to collimate just below the patellas. On the sides, we're collimating to the ischial tuberosities, and on here we're just waiting on our patient to finish sending here, but to get ready for the one that we're about to do, our software automatically creates a request for the x-rays. So if we wanted to manually input one, we would hit our plus button here. We can enter in all of our patient information and hit the next button to select what views we will be performing. Since this patient is already requested, we can go back and we can search to pull up his information. So then we would go here, and then we would press this button to add more views. We'll be doing our VD pelvis film. So we want to start off with them in laying on their back. So we're going to collimate our film from the top of the pelvis all the way down to the patellas, the cranial portion of the tarsus. So we want to make sure that when we rotate our legs that the patellas are superimposed over the trochlear groove and they are parallel to each other. We're going to start getting him into position. And when I rotate his legs, we're not quite getting far enough down to include the patellas. We're going to move him a little bit. Okay, so we have good positioning there. Put on our gloves and get his picture taken. Okay, our legs are parallel. Shooting. Okay. We'll look at our picture. Make sure that looks nice. All right, and that is our pelvis view. Our hospital uses digital imaging, so we are able to pull up patient information on the screen here, so I'll show you how to do that. We are at our main screen. This is what we look at when we first come into the radiology suite. In our search bar, we can type patient name and last name of the owner, and then we'll click our search by patient, search. Cleared it out. I don't know. So here's the patient we want to retrieve. We know it's our patient because it does start with a V. E is for emergency and D is for surgery. So now we've pulled up our patient. We can even open our old studies by hitting our pause button here, and that allows us to pull up our older studies. Our patient is getting ready for the CT, so I'm going to explain how the process is going to work. Right now, the patient's being induced, and then he will come in here. We'll do a survey scan so we can set up our collimation on the computer. And then once the survey is completed and all the measurements and collimation looks good, then we'll do our pre-contrast scan. Once that's completed, we'll give the omnipaque contrast, and then we will do our post-contrast scan and have the doctor review. We're here in CT, we're getting ready for a chest CT, and and our patient will be receiving Omnipig as a contrast. So after we give the contrast, I will show you the before and after images. Giving our Omnipig contrast now, insert that into the IV line. I do need to push this fairly quickly so that it will not be out of the system by the time we can take our next images. Contrast is in. We're going to be flushing with saline now. All right, now we're ready for our post-contrast study. All right, we're going to review our images after we did our CT. We did without contrast first and then with contrast afterwards. We have without contrast on the left-hand side of the screen, with on the right-hand side. And what we're able to see is the contrast going through the blood supply, and it's much more obvious on the with contrast than without. And as we're going through the CT, we'll be able to see the lungs starting to develop here and the blood supply to the lungs. And this patient was diagnosed with pneumonia, so we can see some very busy lung tissue here, and then we'll get into the bottom and we start seeing a lung mass developing, and we can see the blood supply to the mass better with our contrast. I'm here with my preceptor, and she's going to provide some feedback on my radiology course.
Hi, my name is Priscilla Martinez, LVT. I am one of the heads of the procedure team. Since Jana has started, primarily focusing on her radiation techniques in conjunction with working with the cardiology team. She's done a really good job of being more mindful of collimations, being more mindful of positionings, especially sternum to vertebrae techniques. She's been more mindful of her PVPs and her MASs. She's done a really great job of being picky with her images, which is very helpful in this field.
Thank you, Priscilla.
You're welcome.